Welcome. On behalf of the Board of Directors at ABEM, we welcome you all to this update on the board's virtual oral exam. On the call tonight, we have reps from CORD, including program directors and coordinators. There are residents, there are recent grads who are joining us, and also educational staff from the academy and the college. So welcome to you all. You know, it's a testament to your dedication to our specialty that in addition to treating patients, caring for patients during this pandemic, you've been caring for your families and caring for your own health. And in the midst of course, interview season, here we are together tonight. Thank you, thank you, thank you. All of the organizations, you know, across the country in 2020, of course, ABEM's no different. We've all been working hard to figure out how to adjust, how to pivot, how to innovate. And tonight we're going to hear from Karl Chudnovsky, the chair of the Test Administration Committee for ABEM. He's also the chief examiner of the oral exam, and he is the chair of the virtual oral exam task force that has been working on revisioning a temporary virtual oral exam since early this summer. Karl, I'll turn it over to you.
Thank you, Marianne. I appreciate it. And let me add my welcome to everyone and my thanks and appreciation for you all being here today. I hope this will be informative. If you have any questions during the presentation, please put them into the question bank. We have someone monitoring that. And at the end of the presentation, I'll try to address all of the questions that we have time for. So without any further ado, why don't we go ahead and move on. Next slide, please. We did that one. All right. So over the next half hour or so, my goal is to provide you with an update on the development of our virtual oral exam, provide you an overview of that exam. I'm going to spend quite a bit of time talking about the format because I'm sure that's what many of you are interested in. And we actually have a video demonstration of some of the new aspects of the exam. I think that'll be very helpful as you try to understand the directions that we're going. Let me start by answering a question that always comes up, and that is, why do we still have an oral certification exam? Well, the main reason, the bottom line, is that the oral exam tests different things than the qualifying exam, than the written exam does. You all recall that all of our tests, written exams, all of our continuing certification stuff is all based on the EM model. Within that EM model, we also use what's called KSAs. That stands for knowledge, skills, and abilities. And we have used these KSAs for quite some time now. We have polled thousands of emergency physicians over the course of the last decade or so to understand what are the skills and the knowledge and abilities that are most important to the practice of emergency medicine within the EM content. And so we use these KSAs when we write our questions for all of our exams. Over a third of the KSAs that we would like to test are not able to be tested on the qualifying exam. And that's one of the main reasons we need the oral exam. The oral exam, it tests different skills such as data acquisition, problem solving, empathy, judgment, reasoning, decision-making. Those are important skills for emergency physicians, which we need the oral exam to assess. So a little background on where we've been and why we are here today. I know you all recall that both the spring and fall 2020 oral certification examinations were canceled due to the COVID-19 pandemic. That's resulted in approximately 2,300 physicians who have taken and passed the QE exam and who are in the queue waiting to take the oral exam so that they can become board certified by ABEM. We've run into some challenges, as you know. First, we've looked at our e-oral platform, and it is not able to be used for a remote exam. And as you might expect, doing this exam remotely is much more difficult to administer and really has created a number of issues for us. The result of that has been ABEM has created a task force called the Virtual Oral Exam Task Force a number of months ago to begin to work on creating a virtual oral exam that we could administer remotely and that would help us get this backlog of candidates certified. I've been leading that task force that has been meeting regularly over the past several months, and I'm happy to report. And the reason we're here today is we are ready to move forward with a new virtual oral examination. The first virtual oral exam is actually scheduled, and that's going to be in December. It's going to be a smaller exam than we anticipate the remainder of the exams to be, somewhat of a pilot, so that we make sure that it does work as well as we anticipate. We've also begun scheduling additional exams in the first half of 2021. They will be in March. There'll be another one in mid-April, and a third in either May or early June. During this period of time, we will determine what the administrations will look like on the second half of 2021. And that's going to depend really on the state of the pandemic, things like vaccine development and deployment. And that will help guide us with what we do the remainder of 2021. One of the things that we are not sure of, and that is the scalability of this virtual oral exam. We don't really know how many candidates we can put through at any one time because it's really determined by the number of available examiners that we have. Nevertheless, during this pandemic, the VOE will be the format that we will use. No decisions have been made about the oral certification format after the pandemic. We are considering all possibilities, from going back to doing in-person exams to continuing virtual, some hybrid. So we are looking at all of the potential ways that we might go. One thing to remember is that even if we go back to a in-person exam in Chicago, it will have to be under somewhat of a different format because we now have so many graduates coming to take the exam every year. It's gotten extremely large, and we cannot accommodate that number based on our current environment, the pre-COVID environment. So we'll be looking at ways to handle the large numbers of candidates that we have. When we look at the upcoming exams, a few points I think that you'll all be interested in. Candidates who were scheduled in 2020 who could not take the exams because they were canceled will be scheduled first for the virtual oral exams. So we'll start with the spring 2020 candidates and then move to the fall 2020 candidates. And these candidates will be randomly assigned to the 2021 administrations. Those candidates who are assigned to the December date will be notified the week of November 9th, so basically this week, that they'll be taking it in December. And candidates who are scheduled for those first 3 administrations that I talked about in the first half of 2021, they'll be notified in early January. Let me talk a little bit about the schedule. So our plan is to provide 2 exam sessions per day. Each session will be approximately 3 hours long. The cases will be scheduled every 25 minutes. This is a little different than our pre-COVID exam. We're allowing 15 minutes for the actual case, which is typical, and 5 minutes for the examiners to score, which is also something we've always done. But for this exam, we're adding an additional 5 minutes to each exam to help with the transition from one candidate to another. In addition, there'll be a 10-minute break during the exam session to give the candidates a little bit of time to cool out a little bit. The biggest difference in the schedule, besides the additional 5 minutes, will be the fact that in the virtual oral exam, the candidates are stationary, and it's the examiners who will move from room to room. Normally in our in-person exam, the candidates will go from one room to the next to take different exams, and the examiners stay in the same room. That's going to be reversed. So once a candidate logs in and is placed in a Zoom room, they will remain in that room, and the examiners will go from room to room to provide the exam. All right, let's take a look at the format of this new exam. So in general, there'll be no triples in this virtual exam. We will have 6 single cases for each candidate and 1 structured interview case. This is new, and I'm going to talk about this in a moment. There'll be 1 examiner for each case, and the stimuli for this virtual exam will be static. There'll be no moving images or videos for the exam. And the way the candidates will access the stimuli is also a little different. Again, it's going to be via Zoom, and I'll explain that when we move ahead. All right, let's talk a little bit about the single cases. These cases will be very familiar to all of you. They are similar to the cases that we were doing pre-COVID, and they're identical to the cases that we provided in the triple case encounters. Each case in those triples, the cases that we will be providing during the virtual exam are identical to those types of cases. The biggest difference for this part of the exam will be passing the stimuli on the screen. We are using a Zoom platform, and so the examiners will be sharing their screen with the candidates. Each screen will have the same number of stimuli listed for each exam. So for the paper single cases, there'll be 12 stimuli listed for each exam. That case may have 1 stimuli, 5, or all 12, but 12 will be listed for all. When the stimuli are provided to the candidate, it will be by the examiner clicking on that stimuli for the candidate. Unlike our e-oral platform, the candidates will not be able to open and close the stimuli on their own. That'll be done by the examiner. Nevertheless, if a candidate wants to go back and review an EKG or an X-ray, they merely have to ask the examiner, and the examiner will provide that on screen for the candidate. The new case that we're introducing on this virtual exam is called a structured interview case. ABEM is leveraging this opportunity to innovate and create new case formats. The structured interview, it's more of a discussion between the examiner and the candidate, and it follows the approach to a workup that emergency physicians do in the ED every day. One of the main goals of the structured interview case is to really understand why the candidate is providing a particular treatment, why they've ordered a particular test. It's going to allow us to really get into the thought process of that candidate, to really look at their judgment and rationale for why they are taking the actions that they are taking. So as you'll see in the video in a moment, there's a lot of things like, doctor, why did you order that test? Or how will the result of that test help you? And it's going to give great insight into the candidate's judgment, reasoning, and thought process. I think the best way to understand the structured interview is to actually see one. And so what I'd like to do now is to show you a demo of a structured interview. And then when it's over, I will kind of go through it with you again. So if we can go ahead and play that. Good afternoon, doctor. This is a structured interview case. You will have 15 minutes to complete the case. Before we begin, do you have any questions?
No, I don't.
All right. You are asked to see Mr. Parker, a 42-year-old man with epigastric pain and vomiting for the past 6 hours. When you walk in the room, you see a middle-aged man who is uncomfortable and vomiting. The nurse hands you this admitting form.
Vomiting 6 hours, uncomfortable, no history of GI disease, pain and nausea quickly, sharp, unremitting and radius to the back, 10 out of 10, no history of surgery or comorbid medical conditions. He's a little hypertensive, tachycardic, but otherwise unremarkable. Okay.
Right. Based on this presentation, what additional historical information would you want to ask the patient?
Well, I'd want to confirm that, in fact, he's never had any symptoms like this before. He has no history of gastrointestinal disease, but never anything like this before. I'd want to know about his past medical history, particularly a history of hypertension, since he's a little hypertensive here, and if he truly takes any medications. I'd want to know what he was doing when the pain started, if he finds that anything makes the pain better or makes the pain worse. Sharp abdominal pain. I would want to know if he's vomiting. I'd want to know what that vomitus looks like. I'd want to know his last bowel movement and what color the last bowel movement was. I'd like to know his social history, if he's a smoker or a drinker, or if he uses any illicit drugs. I'd like to get a family history, and I'd also like to get a history of unintentional weight loss over the last number of months.
All right, doctor, thank you. You asked about previous episodes or past medical history. Why?
Well, I think the best predictor of his diagnosis today would be previous diagnosis of the same or similar.
All right. You also asked about alcohol use. How is that helpful to you?
I think the alcohol use is important because it can affect the GI system in a number of different ways. It can be a direct irritant to the stomach. It can be associated with nausea and vomiting, and that can give even it can really cause liver dysfunction and increase the risk of GI bleeding, and it can also cause inflammation of the pancreas.
All right, thank you. The patient does drink alcohol infrequently, but drank heavily for him last evening. He had 6 beers and 2 shots of tequila. He has no known history of gallbladder disease. Based on what you now know, what specific physical exam findings would you be looking for?
Well, I'd clearly start with how he looks in general. Does he look sick? Is he pale? Are his mucous membranes pale? Or his mucous membranes dry? Is his mental status okay? I do a heart and lung exam. I'd certainly do an exam of his abdomen. I'd look at the abdomen first, then I'd auscultate and I would palpate the abdomen. I'd do a rectal exam and check for occult blood. I do a GU exam as well. And I just make sure that he was moving all extremities normally.
Right, doctor, you indicated that you would auscultate the abdomen. How is that helpful?
Well, I think a sudden onset of nausea and vomiting can be a sign of a bowel obstructions. So I would want to make sure that he had bowel sounds. If they were high-pitched bowel sounds, I'd be more worried about a mechanical obstruction. If bowel sounds were absent, I'd worry about an ileus, whether that was from medication or from some other cause.
Right, doctor, and you indicated that you would want to palpate the abdomen. Again, how is that helpful?
Well, I want to make sure, given his, hopefully I would be able to tell, given his body habitus, if he had a pulsatile abdominal mass, if this doesn't sound like a AAA, but clearly thinking worst first, I would think about a vascular emergency. I would also want to see how tender he is and exactly where he's tender. So looking for peritoneal signs. I'd also check and make sure that there wasn't specific tenderness, despite him complaining of tenderness in the mid-epigastrium in the right upper quadrant, or that he had a Murphy's sign.
All right, doctor. The patient is slightly diaphoretic and appears to be uncomfortable and nauseated. Oral mucosa is dry. There is moderate epigastric tenderness without rebound. Bowel sounds are normal. Stool is negative for occult blood. And the vascular exam is normal. Based on what you now know, what are the top 3 items on your differential diagnosis based on the most likely conditions?
We see this pretty sick with mid-epigastric pain. I think I'm going to focus on the, it still could be a lot of things. So could be peptic ulcer disease, could be gallbladder disease, could be his pancreas. Not typical for mesenteric ischemia, but it could still be mesenteric ischemia. Could be gastritis. Not typical for primary hepatitis with a sudden onset, but that's still a possibility. How many more would you like me to give?
Well, actually, doctor, if you would, I'd like your top 3 only, please.
Okay. I think this could be peptic ulcer disease, pancreatitis, with or without a gallstone, or I'm still going to leave mesenteric ischemia on.
Right, doctor. Thank you. Based on what you now know and the working differential diagnosis that you just provided, what, if any, diagnostic studies would you order?
I'd like to get a CBC and a BMP. I'd like to get liver function tests and a UA. I'd like an EKG and a troponin. And I'd like to get either a right upper quadrant ultrasound or a CT abdomen and pelvis. I guess given the location of his pain, I'd like to go with the CT abdomen and pelvis. I don't think a right upper quadrant ultrasound. Yeah, CT abdomen and pelvis.
All right, doctor, thank you. You ordered a BMP. Why?
Well, his I think that he's volume contracted given his tachycardia and the oral mucosa findings on his physical exam. So I would want to make sure that he doesn't have an acute kidney injury associated with the volume contraction.
All right, and similarly, you ordered a CAT scan. How would that help you?
I think given the two diagnoses that are at the top, I guess I could have gotten a chest x-ray to make sure that he didn't have free air, but he doesn't really have peritoneal signs. So I think a CT would tell me more about gastric as well as pancreas and biliary disease than just a right upper quadrant ultrasound. So it would definitely show me free air. It would show me gallstones. I might get an estimation of the common bile duct, and it would give me a general look at the pancreas as well as a look at the vasculature.
All right, doctor. Here are the results of the lab and imaging studies.
Okay, a little bit of a white count. Hemoglobin looks normal. Oh, lipase and amylase. Very pancreatic fat stranding. Okay.
All right, doctor. Based on what you know now, what treatment, if any, would you order?
I would start IV fluids. I'd give a liter bolus, reassess after the liter for a second liter. I would give him some antiemetics, some medication for pain, and I would make sure that nursing is aware that he needs to be kept NPO at this time.
All right, doctor. You ordered IV fluids. Why?
Well, his physical exam with the tachycardia and the dry mucous membranes is consistent with volume contraction, and those are really borne out in his labs with bicarb of 17, mildly elevated lactates, and a BUN to creatinine ratio of over 20 to 1. So I think he would benefit from IV hydration. That, and I'm going to be keeping him NPO, so he's going to need maintenance fluids anyway.
All right, and why would you reassess the patient?
I think I need to reassess his vital signs, but I also think that this lactate is elevated, and I think it's going to be important to trend lactates on him to make sure that we're doing adequate resuscitation. So reassessment to me means not only vital signs and clinically, but I would repeat his labs in a couple hours.
All right, thank you. Based on everything you know about this case, what is your final diagnosis?
Primarily giving the CT findings and his labs, I think it's acute pancreatitis, but don't see evidence of common bile duct obstruction.
All right, thank you. That's good, thank you. Based on what you know now, what should the disposition of this patient be?
Yeah, he needs to be admitted. Probably admitted to a step-down unit or at least a monitored bed, someplace where there's adequate attention to him.
Okay, why would you admit him?
For a number of reasons. He needs to stay MPO for pancreatic rest. He's going to get IV fluids. Probably going to have a continued need for parenteral pain medication as well as antiemetics. And I think most importantly, he's going to need serial abdominal exams. He doesn't seem to have any surgical complications of pancreatitis yet, but we need to trend his labs, including his H&H, and follow serial abdominal exams along to make sure he doesn't have any complications.
All right, thank you. Based on the disposition that you chose, which is to admit this patient, how would you hand him off?
Well, I'd reassess and see how he's doing and put in labs in a little bit of time. I think, though, he can be admitted to medicine, so I would make sure that the admitting team or the admitting physician knows that I have a middle-aged gentleman with no significant past medical history presenting with acute epigastric pain, and it's consistent with pancreatitis, not associated with gallstones, but probably secondary from his acute alcohol use. On presentation, he was tachycardic and hypertensive, but in pain, and afebrile, but his workup has shown an elevated lipase and amylase. CT consistent with pancreatitis with peripancreatic stranding, but no evidence of hemorrhage. I've treated him with IV pain medication, started IV fluids, and he needs serial abdominal exams. And I would ask them if they had any questions about his care or needed any clarifications.
All right, doctor, thank you very much. That ends this structured interview.
Thank you.
All right, so I think that gives you a great look at what the structured interview cases will be like. You might have noticed that it did not appear as clear as you would like, and that's really because we're showing you a recording during a Zoom webinar. When you look at it through the normal Zoom platform live, the images and the individuals are very clear. And in fact, if you go on our website, this video has been posted to the website, and you can view it again, and you'll see that there is great clarity. I also want to mention that we have posted a video of a traditional case presentation with the new virtual oral platform. So if you want to see that, you can go on to the ABEM website and view that. You noticed on this video that there were 6 stimuli listed on the page. You'll see that on all of the structured interviews. And again, as I mentioned earlier, on the case presentations of the typical oral exam cases, you'll see 12 stimuli listed. Again, both this video and a video demonstrating the paper case presentations are available on the ABEM website for you to review. All right, talk a little bit about some of the security considerations for this exam. This is still a high stakes exam. It has a tremendous impact on our candidates. Candidates will not be allowed to have any external assistance, no open book, nobody in the room with them, just them. They'll need to find a nice, quiet, private testing location. We're going to ask them to attest, sign an attestation statement, attesting to the exam policies that they've been informed and they know and agree with them. But this is strictly an honor code exam. We're going to rely on the candidate's integrity to follow the rules. Nevertheless, I do want to mention that violations will have consequences, as do violations during our other exams in the past. During exam administration, candidates will have a check-in process for each session. There'll be a systems check to be sure that all of their applications are either closed or turned off. There'll be a process for candidate authentication, and ABEM is working with a vendor to help with this process. We plan to do a visual scan of the environment to be sure that the candidate is alone. We also will be having proctors who will circulate through the Zoom rooms to kind of watch what's going on and to act as a proctor for the exam. All of the sessions will be recorded so that we can go back and we can review any part of the exams that we would like. For all of our exams, the ABEM staff does web patrolling, looking for exam content online, and we will do that for this exam as well. Prior to the exam, we plan to email candidates a number of pieces of information. They will all receive candidate note sheets that they can take notes on during the exam. They'll all receive a list of normal lab values and common abbreviations. And we're going to send them information regarding the structured interview format and information about scoring so that they'll know how they're being assessed. And as I said, they'll also be able to go on the website and view the video that you just saw. We will ask candidates to destroy or shred the notes that they took prior to the end of the session. Next slide, please. There we go. As I mentioned, candidates will be asked to find a private testing location that is free of distractions. They will need a laptop or desktop computer. You cannot take this exam using an iPad. The laptop or desktop will need a camera and a microphone. And we're going to strongly recommend that they have headphones with their microphone. They'll need high speed, reliable internet access. They'll need to test their internet access before the exam. We found that hospital firewalls can throw havoc with some of these Zoom presentations. And again, the examiners will be sharing their screen with the candidates to provide all of this necessary stimuli. All right, that kind of ends my presentation. Kathleen Ruff has been monitoring your question and answer room. And so I'm going to ask her to provide me with some of those questions and see if I can provide you with some of the answers.
Hi, Carl. So one of the questions that have been coming in is related to the scoring for the structured interview. So can you talk about the scoring that's going to be used, the criteria, how candidates will be evaluated, what's the scale, is it objective, subjective? Can you speak to the structured interview scoring?
Sure. So all of the case developers for the structured interviews have identified the most important information that the candidates will need to provide to the examiner during the exam. Each time they get a piece of that information correct, they'll score a point. In addition, you notice that during the demo that I asked a lot of whys or how that would help you. That's looking at the candidate's rationale and assuming that they have the correct answer and the rationale for that answer is appropriate, they would also get a point for that. And there'll be a number of sections. So there's a history section, as you noticed, a physical exam section, differential diagnosis, testing, treatment, final diagnosis, disposition, and transitions of care. And those are the categories that they will be scored on.
So another question is, will there be actual images or just interpretations of imaging studies?
So there'll be both. There may be chest x-rays and EKGs that the candidate needs to interpret and use in their evaluation of the patient. There also may be written reports of those same entities. So it varies from case to case, but there will be static images for sure of x-rays, EKGs, possibly CTs and ultrasounds as well. There just won't be any dynamic or videos in this exam.
Could you also clarify the use of the e-oral software? I know you touched on it in the presentation, but to be clear how the e-oral software is or in fact is not going to be used during the virtual oral exam.
We have been working with our e-oral software vendor, and unfortunately, the current platform is not suitable for remote administration. So we will not be using the e-oral platform in the virtual oral exam. As of right now, we will be using a Zoom platform. As I mentioned a moment ago, we have a vendor that we're working with to help with the check-in authentication and scheduling processes, but the actual platform will be Zoom. Moving forward, we will be investigating a number of possibilities to improve the platform and what we might be using if and when we go back to an in-person oral exam in Chicago. But for now, I want to be clear, we're using a Zoom platform. There will be no e-oral platform.
So we have a couple of technical questions related to, so what happens if a case gets interrupted by a coworker who walks in, a family member, you know, that type of situation? How is that going to be approached in the exam?
Sure. So we have technical difficulties even in our in-person exams, and we have processes in place to manage those. For the virtual exam, if it's a minor interruption, a notification bell rings or someone walks by and knocks on the door, as long as it's minor and brief and doesn't interfere with the exam will continue on. If there are significant impacts, prolonged technical difficulties, we have processes in place to manage those. So we will have backup examiners that are available in additional rooms that the candidate could quickly go into if it happens early in the exam. We have makeup sessions that will be planned should a candidate be in the middle of a session and can't go to a new room, but yet couldn't finish the exam. We'll schedule them for a makeup session. We plan to have the candidate's cell phone numbers, and our chief examiners will have those along with the team leader and examiner numbers so that we can communicate rapidly if necessary during the exam when issues or problems arise. You know, we're keeping our fingers crossed that this is going to go very smoothly. Most of our candidates are going to be very familiar with Zoom because they've been probably using it for the last year or so. But things are going to happen. We know that. That's inevitable. We will have processes in place to manage them, and we will be sure that every candidate gets a complete, full, and very fair exam.
So how do we help candidates prepare? What are some of the things that would be suggested to help as a candidate goes into an oral exam administration?
All right, that's a great question. So for the actual administration of the exam and taking the exam, the 6 cases that they will receive are virtually identical to the types of cases they were taking prior to COVID. And so your ABEM practice sessions will be great for those, and I wouldn't change those at all. Very similar. For the structured interview, I strongly recommend that the candidates view the structured interview demo on the ABEM website so they can see it. We will be sending them information regarding the format and as well as the scoring, and I would strongly encourage them to review that. They can contact ABEM if they have any questions prior to the time they take the exam. Also, it's really important that they abide by the rules and regulations and the technical aspects of the exam. So be sure that they find that quiet place with high-speed, reliable internet that they test before they actually sit for the exam to be sure it works. All of those, I think, will help allay their fears and make them more comfortable for their test day.
So is the virtual oral exam going to be proctored? Is it going to be recorded, observed? What's that situation?
Yes, all of those things. So all of the exams will be recorded. So unlike our in-person exams in Chicago, we're going to have the ability to go back and review any aspect of any exam, which I think will be very helpful to us. In addition, we will have proctors who will log into an exam room and just observe what's going on. They'll be able to look at the candidate's body language and environment around them on the Zoom screen. So they will act as true proctors. And then we will have observations as we do now, as we've done in the past with our e-oral exam in Chicago. We work hard to be sure that our inter-rater reliability is top-notch, and we have observers scoring the exams in addition to the person administering the exam to be sure that our scoring really is good. So all of those things will happen during the e-oral platform as well. I'm sorry, during the virtual platform as well.
Yeah. Can candidates take notes? I mean, can they write down information as the case goes along?
Absolutely, and I encourage them to do that. No different than during the pre-COVID oral exams in Chicago. We will be sending all of the candidates note pages so they can take notes. What we will do, however, is to ask them to destroy those notes while still on camera before the end of this session. But absolutely, they should be taking notes, and I think that will help them during the exam administration.
Another question is about the images themselves during the session. Will candidate be able to, while they won't be able to interact directly with the stimuli, will they be able to magnify the image on using the Zoom platform?
Yes, they will. They can enlarge X-rays, EKGs, and any of the stimulus test results that we provide for them. Again, they won't be able to open or close those on their own. They will not be able to directly interact with those stimuli. But once the stimuli is on screen, they can enlarge it so that they can view it more easily. As I said, if they want to go back and relook at a stimuli that they had done previously, they only need to ask the examiner, and the examiner will make that available for them.
Can you talk about time management in terms of candidates and they're anxious to make sure that they get the case done on time? You know, now a structured interview, it's a new case type, but it takes the same amount of time. Can you just talk a little bit about the time management aspects of the virtual oral exam?
Sure. So our examiners are extremely well trained to help keep the candidates on track and on time. And they will be responsible for being sure that a candidate gets their full 15 minutes to complete the exam. However, they will not let the candidates go over. So it is a 15-minute exam, but during that time, the examiners will do their very best to be sure that they're moving the candidate along at a good pace. The candidate will not get any clock or anything like that to view during the exam. They certainly will have their computer clock, but the examiners, again, are well-trained. They know the timing of the cases, and they will be sure to move the candidate along so that they can finish the case in 15 minutes.
Are there any limitations to the internet browser that can be used during the virtual oral exam?
To my knowledge, virtually any browser can be used. We certainly recommend Google. We've developed it and practiced it with Google, and it works quite well. But Firefox or some of the other ones are still as well okay and should be able to be used for the exam.
And can you clarify the dates for the December 2020 administration and recall when that information will be going out to candidates, which I think is actually this week, that information is going to go out.
Sure. So the first exam, again, this is going to be a little smaller scale than the ones we have planned for 2021. But we're planning to run this exam on the 16th and 17th and 18th of December. The 16th and 17th will be full sessions all day, and the 18th will be a shorter session, and that will be able to get all of the candidates we have planned for that session through the exam. The additional exams in early 2021 are planned for March, mid-April, and then late May, early June, and those will be larger exams.
Perfect. Well, those are all the questions we've received to date. So thank you so much for answering those for those that are on the call. And then this will also be available on the website.
Well, again, I want to extend my appreciation to everyone on the call or on the webinar. Really appreciate your time. As Mary Ann said, we know how busy everyone is, and with COVID and volumes going through the ceiling in a lot of places, we know that you're very busy, and we appreciate you taking the time to review this with us. I strongly encourage everyone to, again, go to the website and to view the demo again, as well as the demo for the traditional case presentations, and to email ABEM with any questions or concerns that you have. We're very optimistic that we're going to be providing a great exam for the candidates, and we will try to get this backlog of candidates done and get them board certified and moving on with their careers. So again, thank you so much. I appreciate your time, and I enjoyed speaking with you.